All right, I have 1 minute past the hour, so let's go ahead and start. And I think you all saw you know, everything that Dr. Smith is involved with, and it's when I read that, it's like, wow, how do you have the time to do other stuff in your life? And so, in brief, he's an associate professor in the University of Utah Intermountain Healthcare Department of Population Health Science in the Spencer Fox Eccles School of Medicine at the University of Utah, and he directs the Dissemination and Implementation Science core of the Utah Clinic and Translational Science Institute. Those two things in and of themselves are a mouthful. And so I feel really lucky that we have you here today. The title of his presentation is going to be Considerations for Building a CFHA Measures Repository. And as a brief overview, measures repositories can be useful for not only researchers and clinicians, but also healthcare system leaders when they're designing studies and evaluations of clinical practices. And his presentation is going to discuss some of the effective practices for making a measures repository as useful as they can be for a diverse user base. And he's going to provide tips for developers and curators of measure repositories, easy for me to say, with the aim of being pragmatic and rigorous. So, Dr. Smith, the floor is yours.
Thanks, Chris. Yeah, really happy to be able to share some thoughts and some learnings on this topic. So first thing I wanted to ask actually is how many people have actually been a user of a measures repository? You do the little thumbs up emoji, hands raised. Okay. We've got one user. All right. Jody, what was your experience if you're in a place to talk?
Yeah, I am. Just shy. Just kidding. My experience was it looked better than it felt in that the measures, once you drill down into the measures that were available, they were like not a great match for exactly what I needed. Now, I can't exactly remember what I did, but I may have adapted some things, right? But it wasn't as easy as just going and picking, an apple off of a low-hanging branch of a tree. Like it took a bit of extra work. Still in all, probably a time savings over searching literature.
Anybody else have experience with the measure repository?
So, in my experience, I've gone and looked at some different measure repositories, and I think some of them can be well designed, some of them are not so well designed. And I think, the average person that goes to one, I think it can be a little bit overwhelming. And so even when you know what you're looking for, and when you click through things, if they're not explained well and they don't show you how to get that measure and what is its what are the psychometric values, what's the functionality of that, how long does it take, it can, I think, can be, I have the attention span of a gnat sometimes. So if it takes me more than about 60 seconds to find something, I'm off and I'll just Google it and try to find it myself. And so that's typically the way I've looked at measures when I've been using them for clinical practice. I would just go and I just look in a scientific database and look through the psychometrics myself and figure that out. But I think that's not what most people who want to use these measures would necessarily do. So that's my experience.
Anybody else experience or reasons maybe you haven't actually, knowing that they exist and maybe have chosen not to go seek out measures through a repository?
I would say I know that they exist like in a hypothetical way, but probably wouldn't know directly where to search for the type of measures that I would want, I guess.
Yep.
Our organization has also utilized a lot of the data aggregators, like your HIEs and so on, and they've been helpful to assess pools of patients with similar types of potential modalities, diagnoses, and so on, but actual measures and actual target to goals, if you will, because a lot of the stuff that we do is, you're treating to target, and those targets aren't always readily available in some of those areas. So something that like what you're developing could be very useful.
So you're thinking more like a measurement-based care approach, Bob?
Sure. Sure.
Yeah.
I mean, if you think about patients with multiple, with all the comorbidities out there, and certainly those with polypharm, the equation as to the potential for care and outcomes is vast. And so if you can narrow that down for clinicians as decision makers, especially primary care, they have no time to be dealing with this, you
Yeah.
know? So it's one thing for them to be dealing with a comorbid or to be dealing with a behavioral health patient. It's another thing for them to be dealing with a behavioral health patient that has diabetes, COPD, and is on 17 medications.
Yeah, I think actually what you're bringing up is even a more downstream kind of application of measures repositories of once you actually have measures and you have data, how do you feed that back to decision makers, whether that be individual clinicians, practice managers, higher ups in health systems, and potentially for both of those audiences, how do you actually have data visualization or just presentation of data that is meaningful and helpful for clinical care?
Yeah, I mean, we work with primary care
Today,
groups.
but
Yeah, we convince them to sign up with HIEs for just that reason, because you want to see how everybody else is doing, and if you could take that information in and then massage it through data analytics in your practice, it's a very helpful tool then.
yeah,
Not everybody has that ability, but if you could,
yep, for sure.
just some thoughts.
Yeah. So I took a perspective of essentially you all. So as potential decision makers of CFHA who would have to propose this, potentially be part of actually doing the creation and the background work necessary to create a measures repository. That's kind of the perspective that I took. So let me go ahead and do my customary PowerPoint screen share. Always fun, right? Everyone loves PowerPoint. Actually, we hate it, but it's fun. So yeah, I'm just going to jump right in. So the biggest question I think that, tends to be the motivating factor for users, is really kind of this whole question of what's the best measure for this thing. And sometimes we have our pet measures, sometimes we have ones that we're just familiar with. We might ask our colleague, down the hall who does work in this area, what's the best measure? Which can, be useful, but there's probably a lot of other measures out there, and there are other considerations that you may want other than just someone's expert opinion or word of mouth. Or, you'd find a paper in JAMA last week that's, similar kind of research as you, and they use this measure, so it must be great. So we kind of run into this issue of what do you do when you're really trying to figure out what measures. So just kind of to level set and get all on the same page here about what a measured repository is. So it's a database of measurement and assessment tools in a variety of specific domains. And so the specific domains thing is going to come up a few times as we get into what potentially CFHA might consider doing if they were to take on a measures repository. And what it's supposed to do is simplify the process of finding, comparing, and accessing measurement tools. And as Jody already mentioned, and others who have tried to access these, the simplifying part of this is not always achieved. I've had a similar experience with trying to use measures repositories that they're both somewhat overwhelming at times, and sometimes they don't feel like they actually have the kind of information that I was looking for, the kind of considerations or factors that would lead me to pick a particular measure over something else. I intentionally did actually highlight these three different sort of aspects or features of repositories, because that is going to be an organizing factor in this discussion today. But yeah, so really what they're supposed to do is help you understand the key features of each measure. And those can be things like psychometric properties, potentially how long it takes to administer the tool, and some other things. And we'll take a look at one very recent method for actually looking at different features that were deemed important. And of course, you want to be able to make informed decisions when selecting measures. There is no measure out there that is perfect in every psychometric capacity, is also low cost, is also pragmatic, is also actionable. So you're always kind of having this situation of having to weight particular kinds of features over others, where in a research context, we may really want to have things that have really strong psychometrics, where in potentially a clinical practice application setting, you're okay with slightly less good metrics if you have really good pragmatic and low cost and actionable data that comes from those measures. So it's really hard for a repository to simply say, here's the best measure for this situation, because every situation is going to potentially require a different calculus of which features are outweighed and others, and which ones you'd be okay with having kind of a poor rating versus needing to have a high rating. So some exemplars. These are some fairly well-known ones, ones that I have been familiar with for a number of years for various reasons. Probably the most well-known one in terms of NIH researchers and folks who are funded by NIMH in particular is a thing called the Phoenix Toolkit. And so the Phoenix Toolkit has a number of different sort of modules or kind of categories that they've taken on over the years. I can't remember where it started. I think it was substance abuse and addiction and mental health. This might actually be in order, to be totally honest. So they basically had stages that these different kinds of measures or different areas of science that they did reviews and then ratings, and actually populated the database in these 6 different areas. So substance abuse and addiction, tobacco regulatory research, mental health research, blood sciences research, social determinants of health, and COVID-19. And you can imagine that actually probably everything here, except for maybe blood sciences, might actually be applicable to folks who are CFHA members. However, some would probably be more or less important, and the types of measures that are being presented here, certainly are going to be running the gamut of different kinds of conditions, disorders, and maybe those are not the things that CFHA really wants to invest in creating a database for themselves or a repository for themselves. So some other ones that are fairly well known as well. There's a thing called GEM that the National Cancer Institute put together, which is the Grid-Enabled Measures Database. This was actually an internal project that was funded through intramural research dollars at NCI. It is not just cancer. It is things that are related to cancer. So there are measures of mental health and coping, resilience, other factors like that that go into, especially like survivorship and cancer control sort of measures. So it could be potentially useful for some individuals, but it really was geared towards people doing work in cancer or some stage of cancer related research. Here's another one that I actually was not familiar with until recently, but came across it in looking for this talk. There's a repository of positive psychological well-being scales that was put together by this Center for Health and Happiness at Harvard. Interestingly, I think one of the things they tried to do is really, instead of having a total like risk-based perspective, which a lot of stuff in the Phoenix Toolkit and the National Cancer Institute's GEM, they tried to take more of a positive resilience and adaptive functioning kind of a perspective to really balance these things out. So this is actually an example of a place that was a fairly specific area within a larger field of study. So some of these measures may actually be here within the mental health research domain of the Phoenix Toolkit, but this is not going to include a lot of those measures since the focus really was on positive psychological well-being. Another one that I came across that may actually be useful, and this was recommended to me a few years ago when we started a brand new project funded by the NHLBI on community engaged implementation research. And it's the National Academy of Medicine's Assessing Meaningful Community Engagement. They took on this project, I believe it started in 2019 or 2018, and obviously took a couple of years to get fully up and running and available to the public. But this compiled a host of different measures around aspects of community engagement. So, things like trust, things like ownership, all sorts of different just constructs about how academic and community partners work together. You can imagine that some of the measures in this particular repository could be useful for CFHA as well. When you have academic and community partnerships. And community partnerships was very broadly defined. So this could actually be like community health centers. It could be community-based organizations. It could be social service settings outside of the health system itself that you may be doing research on, or doing evaluations of referrals of your patients to those places, and whether or not they actually are able to access those referral sources. So these are, again, just some somewhat relatively well-known, but also germane to the potential topics that CFHA may be interested in. I will say too that just in my own experience of trying to use the Phoenix toolkit, it is quite overwhelming and is not particularly easy to navigate and make decisions about different measures, especially like side-by-side comparisons. It does have really good information about each measure, but it doesn't go as far as it probably could in actually being informative for a decision maker. And what's really challenging about the Phoenix toolkit is that, NIMH and some other places, NIDA has also done this too, in certain research funding opportunities, they have said you have to use, or they encourage use of measures that are in the Phoenix toolkit. And this is particularly true in research consortia. So there's one thing I will talk a little bit about today, but we can talk, it's not on any slides, and if we want to come back to this, is really the idea of potentially having data for synthesis across projects, which really means like endorsement of specific measures and metrics, so that you really can actually combine the data across projects, and it's not, and you're working towards a larger goal, I guess. But that's sort of a higher level application of some of these like shared measures and common metrics that might be done. So the case example that I want to run through with you all was actually undertaken by a similar society, right? So CFHA is in a similar position that the Society for Implementation Research Collaboration was in back in about 2015, 2016, when they decided to propose and undertake an instrument repository for implementation science measures. So I'm going to actually run through their process as just an example of kind of what is required, what kind of research came out of this, and also because they've already done this research, these are actually some really good tools and processes that CFHA and other organizations could potentially follow if they were interested in doing a similar kind of measures repository. So they actually published a methods paper, essentially the steps that they went through or planned to go through. This was back in 2015, like, as I mentioned. And this was their instrument review project, is what they called it. So I mentioned that there's kind of three big aspects of repositories. One is finding, the other one is comparing, and then the last one is actually accessing measures. So let's go through finding. So there are kind of two different ways you can do this, and you can also combine these, which I'll talk about too at the end. The first option is to do a systematic review of the literature, which it tends to be exhaustive. So you tend to get every measure in the world, hopefully, assuming that your search strategy and your coding and everything was good. Anyone who's done a systematic review also knows this is exhaustive. This is a very time-consuming process. It requires many, many, many person hours, not something that can be done on a shoestring budget. Potentially could be done by undergraduate or graduate researchers, probably graduate. But again, it's typically a lengthy process. It is, again, intended to really have an exhaustive look at the literature and take a look at pretty much every measure in whatever domains and constructs have been pre-selected for that search. The other option is to have an expert panel essentially help you conduct a targeted review. So in most situations, the expert panel precedes the systematic review of the literature to basically narrow down exactly which constructs, which syndromes, which disorders, et cetera, which processes may be relevant to the particular end users of this measure repository. This tends to lead to a much more targeted review. It is not going to be exhaustive, and that's intentional. The other option too is that sometimes expert panel reviews actually start with recommending the measures themselves, not just the constructs, and then either a scoping or snowball or reverse or forward citations review process or search process occurs to really kind of hone in on a smaller set of measures. So you're not interested necessarily in knowing every measure that's out there. You're interested in providing some options for users that hopefully are, again, vetted and hopefully meet some of the better psychometric features and other features of the measures. So within CIRC, they did actually publish a protocol for their systematic review of implementation-related measures. CIRC chose to base their review on a well-known and well-established implementation science framework called the Consolidated Framework for Implementation Research. They used version 1, which was the one that was active in 2018 when they did this review. And I believe it had something around 45 to 50 different implementation-related constructs for which they did a systematic review for every single one of those. You can see why I underscored and underlined the word exhaustive. This was a major undertaking. So the second, second kind of aspect of measurement repositories is that it should allow you to compare measures that have been identified through literature searches or expert panel reviews. And so the way that you can typically compare is the review panel itself, or the review group that is doing the systematic review. Once you get to the point of you have all of your included measures, is that they rate those measures on a bunch of key features. There are multiple rating systems that have been developed for different measures, and they tend to sort of be both field and purpose specific. And so, in certain fields, the cost and the pragmatic nature of a scale does not matter. It's really all about the psychometric properties, because these are typically like efficacy researchers, folks who are doing, grant-funded research, and that's all. There's no intent to really identify measures for other purposes. And the other thing that has been done, I think, by CIRC, which was really good, was they started to actually look at some of these things that are more about pragmatic and cost related, those things that are actionable for decision makers and clinicians. And so they published a couple of different papers on a thing they called PAPERS, which is the psychometric and pragmatic evidence rating scale, which I think actually is probably the best one that I've come across for the purpose of CFHA. And we'll look at some of the dimensions of it, and I think you'll see the reasons that I would recommend that. So PAPERS dimensions. PAPERS includes 11 dimensions that are scored for every single measure, and they provide really good scoring criteria, exemplars and anchors for each one of the scores. I have some screenshots actually of the rating form that they use, or the rating manual essentially that they use, so we can take a look at some of these different things. But just at a high level, they had an expert panel of implementation scientists and folks who did implementation research actually come up with what aspects and dimensions of a measure for implementation related constructs are important. Like, what things should we even care about when we're rating, and then obviously comparing different measure options. So they wanted to know, is this thing acceptable? And really, it was acceptable both to the user and to the respondent, right? The person who's actually completing it. They wanted to know whether or not there was relative advantage of this particular measure over other measures and methods that existed for that construct. They wanted to know whether it was appropriate, or whether it was deemed appropriate. They wanted to know whether it fit organizational activities, whether it was easy to use. Could it inform clinical practice? So was the data that came from it somewhat actionable? What was the cost? As you might know, a lot of measures are free, but a lot of measures are not free. And some of them cost substantial amounts. Others are relatively nominal, but still a cost involved either on a yearly licensing basis or on a batch of certain number of administrations is typically how they will charge for certain measures. They wanted to know whether it had accessible language. This was an issue in implementation research because there's jargon, there's some esoteric and odd terms that gets used and things that aren't necessarily as straightforward for just a typical respondent. They also looked at accessible language in terms of reading level, especially if you're going to be administering it to patients or recipients of care. They looked at what the assessor burden would be in terms of training for how to learn to administer the scale, score the scale, all those sort of things, and then assessor burden and interpretation. So this really came into when you had results and had to try to figure out and make meaning of what the heck the scale meant. The assessor burden for interpretation was how they interpreted that. And then length. So length was determined to be different than ease of use, and you'll see sort of the anchors that they have the way they differentiated that though. But this really just comes into like the easy to use, the length and cost are sort of some of the major things about is this actually feasible for an organization or an individual researcher to actually use this measure. So here is what they called stakeholder facing criteria that were identified. And I mentioned all these already. But basically they had ratings on typically a -1 to 4 scale for all of these. And they do provide a rationale for why they had the -1 to 4 scale. It had to do mostly with psychometric ratings, but you can see here for acceptable, it's pretty straightforward. It was poor acceptability all the way to adequate, good, excellent, and you got obviously a higher score for each one. Similar for relative advantage. There was no relative advantage or results were unavailable would be your 0, and then you move up and down from there. Similarly for ease, completed with ease, whether or not this was even assessed is always a question as well. For compatible, similarly, it was poor to excellent and actually all these are, but you can just see that the sort of anchor of none is really that this is not assessed, and that happened quite often, which is sort of a challenge when you're doing measures repositories and trying to do these ratings and comparisons is a lot of times there is no research to really inform some of the different features that are here. Here's where it gets a little bit more detailed. It isn't just sort of a Likert rating scale. In terms of cost, they actually had dollar amounts that were espoused to each one of the scores. So the measure is extremely costly, $100 per use or more. You'd be surprised, but there are implementation measures that do cost $100 or more per use. Not too many, thankfully, but there are a few. And then, of course, on the very other end of the scale is that the measure is free. It's in the public domain. There is no cost for its use. For the uses accessible language category, we're talking about measure has language that's really only accessible to content experts, all the way down to below 8th grade reading level, and obviously not using those terms that would necessitate somebody having some expert knowledge or at least familiarity with a field of study or a topic area. And then the assessor burden has many considerations. This one was one of the harder ones, I think, for them to actually get good agreement on, because there's kind of multiple aspects within each one of these. The easiest or best score for assessor training is the measure requires no training and has free or automated administration. Versus, it has a manual, so you can self-train. And the cost for the manual is free or minimal. And then, obviously going down the lane to it requires external expert administration with no option to self-train or train the administrator component. As you'd imagine, this is highly correlated with cost. So there are often situations that the higher cost measures, it's because they require you to send the raw data to a central place. They actually do all the scoring and then send it back to you. So there isn't a way to kind of take that to break out of that loop and have your system or your research team actually do the assessment itself. So The assessor burden in terms of interpretation, again, kind of very similar, requires an expert to score and interpret, versus it has clear cutoffs, value labels, instructions for everything. Calculation is automatic, and yeah, just pretty straightforward interpretation using like standard scores, percentile ranks, things like that, that any of us are able to interpret readily. Then length, they did this based on number of items, since number of items does tend to correlate with the time it takes to complete the measure. Certainly that would also be probably co-varying at least with the complexity or that domain of accessible language. So the easier it is to, the easier and lower reading level, the more items you can do per minute. And so that reduces the total amount of time. But in terms of the way that they objectively tried to measure length, was purely based on just the number of items. So it's sort of an estimated amount of time that it would take to complete the measure. So the results of all of this coding, at least for the CIRC group, resulted in this kind of cool, every time you click on a domain, it shows all the measures that they identified in the systematic review, and it shows all of the different psychometric properties of the measure. These will all be familiar to folks. So they measured the internal consistency, the convergent validity, the discriminant validity, concurrent validity, predictive validity, known groups validity, structural validity, the responsiveness, and whether or not there was normative data available for comparison within these different measures. So this is actually all of the measures they identified for acceptability of interventions. And you can see there are some, so the treatment acceptability rating form actually has none of this material reported. There was not a paper, the paper that they identified did not report any of this validity data, nor internal consistency, which is a little bit strange. But you can see this is, again, this is exhaustive. This is a presentation of every single measure that was identified, all of the characteristics that got measured or rated, and that was available in the literature. This is one of the measures that, or one of the constructs that had quite a few measures. There were others that had very few, 2 or 3, which obviously makes comparison quite a bit easier. But the tendency may be to like go look at a scale that has the most, of the different kinds of validity reported. But that's not necessarily the case. And it's really difficult as a user without actually going to the source material to even convert these into an understanding of, well, what actually is good. This is just if it's present or not and how good was it, but I don't actually know. It doesn't tell me what the concurrent validity data said. It doesn't tell me what the internal consistency was. Is the alpha 0.85? Is it a 0.92? So having some of that actual data is just not actually present here. So I have found this to be a way to potentially narrow down a number of measures, or to, actually just help me become aware of measures that I wasn't aware of before, but not necessarily a great measure for comparing, which unfortunately was the intent of doing all of this scoring, was to do comparisons. And I just zoomed in here so we can take a look at kind of each one of these a little bit closer. But one thing that they did not do that I know a couple of other of the measures repository do is you can select a couple of different measures. I think it's typically up to 3 or 4, and they will give you a side-by-side comparison, right? So they will put them all right next to each other so that you can have an easier way of differentiating between a small number of measures, since, this is pretty overwhelming. And some of them there's a lot more measures that actually have good psychometrics. And so it's really hard to compare if they're not just right next to each other. So the third kind of feature of repositories is the accessing measures, right? So that's the part that's really helpful for a researcher and for an evaluator, is you find a measure that has good properties and has all these nice ratings from the papers thing. And then you want the measure. And not only do you want the measure itself, you want the response scale, you want the scoring, instructions, you potentially want syntax for scoring the measure if it's a particularly complicated one, like has, item-based weights or something like that. You really don't want to have to recreate that. Otherwise, it's not that accessible. It's not that usable for you. So within the different repositories, there is variable availability. So FENEX and some of the others that I mentioned earlier, they require the measure to be available to be included in the repository. So if the author had not made it available or they weren't able to get it from a commercially available source, if it was a measure that had a cost, then it simply is not included. So CIRC did something a little bit differently. They obviously did all of their ratings based on the descriptions and psychometric properties reported in the literature. The problem is only about 50% the actual measure was made available and is directly linked through the CIRC website. So the reason that that was the case is they did not require, obviously, that the measure be made available for it to be listed in the repository. And they did the descriptions based on published data. So people would, of course, report how many items there is, what's the internal consistency, what are some of the validity data, but they didn't necessarily include as a supplemental files or as a figure what the actual items were or what the administration instructions looked like. And so when that wasn't available, it just simply wasn't available. And so as a researcher, it's been frustrating to find a measure I really like, go to the literature, realize it is not available, email the contact author, corresponding author who is retired or is no longer at that email address, and I can't find them. And obviously there's just many impediments to getting that measure when that's the kind of situation. So having a decision about what measures to include, whether or not they are available, can cut down on how many actually get into the repository in the first place. So some thoughts. These were questions actually that you all sent about potentially doing a CFHA measure repository. And this is a place that I have thoughts, of course, but I'm sort of in a privileged position of not having to actually make decisions and do any of this stuff. But here's some of the thoughts that you guys, or some of the questions you guys raised, and I'll have a few thoughts about it. So how do you identify appropriate measures, and how could the REC obviously systematically support people? So we did take a look at CIRC and their process already. Again, I do think it's a really good process, and they certainly demonstrated that it could work. I would very strongly consider whatever CFHA takes on, what is the scope that is, sort of indicated or that you would want to even undertake? Is there going to be duplication of effort? And I mean duplication in terms of, is there another repository out there that already has the same construct? And so maybe there's no reason to actually do that for CFHA members, but you could simply link or direct users to those repositories, say for, brief mental health measures for kids. FENEX has a number, and that there would probably be no reason to do an updated search or to, recreate it in some way just to have it available here. And then, of course, what kind of resources are available to do whatever scope of work you want to undertake for a measures repository. I will say that the CIRC repository was supported by an NIH R01 and R21. So we're talking about multiple millions of dollars that went into the full process that they undertook. Again, it was huge. I mean, it was 50 plus constructs in a very, very diverse literature. So they were pulling measures from, organizational psychology, from org theory and org behavior, from policy research, from psychology. It's just a really complicated task. So potentially narrowing the scope could certainly reduce that cost right off the top. So here is kind of what I have thought as a potential option for identification. So potentially actually starting with an expert panel or a membership survey to sort of figure out what would be the salient constructs to CFHA users, right? So really narrowing it down, like what things do you even want to have available in a measures repository? Would it be things like measures on primary care integration? There's some really good scales about how well integrated behavioral health is within primary care. Certain behavioral health measures that may not be in some of these existing repositories. Would you want some implementation process measures? So things that would help you understand how programs are being delivered and implemented. Potentially, I know there are actually that some don't exist for this, but there are hopefully an emerging science in fidelity measures for different models of care and different interventions that are pretty consistently used by members of CFHA. So things like collaborative care, primary care behavioral health, and some other things like that. And of course, the next step would really be this review of existing repositories to ensure that there's not duplication. So somebody, a team would possibly have to look at, a handful of the more easily accessible, publicly available repositories to say, okay, people wanted brief measures of depression, but, Phenex and other places have that, so we can just direct people there. That would require just linking to publicly available sources and ones that people don't have to pay for, of course. And most of these are funded by NIH or by other places like the National Academy of Medicine, so they are fully publicly available. And then really to decide too, the next step would be to do a systematic or scoping review of the other measures and constructs, or measures for the other constructs that there wasn't an existing source for. And of course, this would require, setting out a protocol for the identification, screening, eligibility, and inclusion that we all are probably very familiar with if you've done any kind of systematic or scoping review. And then probably using something like papers to rate the key features to really, again, be informative for potential users so they can make informed decisions, but also compare between different measures that are there. The last step that I don't know if I like this idea or not personally, and this is something that you all would have to think about is, are there measures that CFHA would want to sort of endorse, right? Like kind of put the sticker on of like, these are ones that our expert team has vetted. In some ways, if you're going to narrow down and have kind of more of a scoping review perspective, and you're only going to include things that are publicly available, have higher scores on certain dimensions or features, you have an implicit sort of endorsement of different measures. But this would actually be like more of an explicit, like, hey, if you're doing this, we recommend this, or this measure. That can be really helpful because that, a lot of folks don't want to do all the homework themselves or have to consider all the different things that they could consider in weighting these different features. And to have somebody say, if you're doing a research project, do this. If you're doing practice-based research, do this. If you're doing something that's just informative to your local practice and there's no intention to publish it, here's a good measure. Some other kind of user-based ideas. So I had thought that for a potential option for at least the identification of what measures to include. Some of the pros and cons of a repository on the website. I mean, obviously one of the pros is it's a really nice service for people who are conducting research or doing evaluation. I mean, this doesn't have to be like, capital R research. But folks who are just wanting to study their own practice, wanting to study the clinics they work in, maybe doing quality improvement projects, but not necessarily trying to, get publications or funding or anything for that research. It certainly could spur more research or higher quality research. Speaking from the perspective of an associate editor of Family Systems and Health and Prevention Science, we see a lot of people who don't do very good research because of their measures. Their measures are just, they're just kind of weaker or of low quality to begin with, and this could help people actually have just better measurement right off the top. What are some of the best ways for people to access a repository quickly and efficiently? I think beyond the obvious of just having a user-friendly website and probably having a consultant that would help with, user-centered design or human-computer interaction for just the display and all those kind of pieces. One of the things that is kind of helpful is some kind of an organizing framework. It would be, I think it's kind of hard if you're going to be like kind of all over the place with the different kind of things that you might want to include. But with the Society for Implementation Research Collaboration, CIRC, they use the Consolidated Framework for Implementation Research as their organizing framework, and their website actually has a CIFHR figure, and you can click on any of the constructs, and it takes you to those measures. It's really straightforward, but again, it's that is sort of limiting in some ways, and maybe would not potentially be applicable here. How have measure repositories worked for researchers? We talked a little bit about this already. I think some work better than others, and it really depends on what is the incentive and driver for someone using a measures repository. Like I mentioned, there has been RFAs and FOAs from NIDA and NIMH and others that say you have to use tools from the Phenex toolkit. And so it has supported researchers' work in being able to, narrow down what is required. But when you're not kind of having to follow those policies or guidance, in order to keep your funding, they don't work necessarily as well, I think, as we would like them to. The free versus proprietary measures, I think this is a decision that has to get made too. Sometimes the best measure out there is a proprietary measure that has a cost. There's probably reasons to include those because certain health systems and obviously some grant-funded researchers would be able to pay for those. And so it'd be useful for people to know that they exist. But I think that, the thing that's really frustrating is somebody who doesn't have funding goes to a measures repository and all the measures for a particular construct are all ones that cost. So that doesn't mean that they're, I guess, if that could mean that no free ones exist, but it also probably it could mean that they just weren't included because they were lower psychometric properties or something like that too. So really trying to find and make available some of the free measures is really important. And then how to build measures from a repository into practice. I don't know for sure. I mean, I'm not, I don't work in a health system currently. When I worked at Northwestern Medicine before coming to University of Utah, they sort of had a repository of PROMIS measures. So PROMIS was developed at Northwestern. There was a huge, library of just PROMIS measures that were available for all researchers and people in Northwestern Medicine health system to be able to use. It's sort of a narrow, application that was just patient-reported outcome measures, but it really, it was kind of they made it really easily accessible and easy to use for practitioners and for researchers doing research in the health system. But yeah, this is kind of a tricky one for me since I don't do work that's quite as tied to practice currently. So those are some of my more rambling thoughts, I think, there towards the end. It's hard to necessarily know exactly what users are going to want and also what scope is possible with CFHA, but those are just sort of my thinking, having been a little bit involved in some of the work that CIRC did, and then obviously being a potential user of some of this kind of stuff. So I guess I have a thank you slide, but we can get out of here and talk.
So JD, thank you for that. I think, at least for me, that was really helpful to sort of, what needs to be considered, what are the pragmatic pieces of this. And my big takeaway is that this is building a measures repository is a complex undertaking, and it sort of depends on what is your end goal that will determine what your path is. And I'd like to just open it up for folks that have questions or thoughts. It's like we have a lot of other people that have joined us as well.
Hi, can you guys hear me okay? This is
Yep.
Anna. Okay, hi,
Yep.
Great, that was awesome. Thank you so much. My name's Anna and I'm a psychologist in Puerto Rico. So one of the things that we struggle with a lot is finding measures that are validated in Spanish particularly. So I'm wondering if maybe that's something that we could consider including, is which one of the measures that we include there are translated to what languages and the psychometric properties of these, because I spend so much time trying to find out, and I end up going back to the same ones over and over, which aren't necessarily the best ones, but it's what we have available in Spanish. So I'm curious if that's something that you guys considered or thought about.
That was not really considered in the ones that I looked at. I know with Phoenix, it is one of the features that you can limit by language availability. I will say though too, one of the drawbacks of the way that Phoenix did theirs is that they will, again, this is like the whole different purpose or different strokes for different folks situation. So Phoenix was intended to be exhaustive. It has every measure out there for certain things. And CIRC is similar. So they will have measures that have been translated, but haven't necessarily gone through psychometric validation. And so, really just being very upfront and clear when you have a measure that's included and you say it's available in Spanish and you have ratings or a separate rating that is done for the psychometric properties of the Spanish version would probably be a very useful thing. And I completely agree with you. I do a lot of work with Spanish speaking, folks. So it's a real drawback to some of the current ways that they've done it. Go ahead, Jody.
Thanks. I just wanted to thank you again. This is really thought-provoking and inspiring, and kind of a cool idea for CFHA. But I think, just an observation, the challenge we would have is, the Research and Evaluation Committee, which, is coordinating your talk today, is missional around trying to inspire people to do research, right? So that would seem to like direct the scope of such a repository toward research focused measures that are geared toward academic study, rigorous study, funded study. But we also kind of have this commensurate desire to see clinicians empowered to collect better data on the ground and recognize the role that plays in improving the more rigorous research studies. And so, like, it's equally exciting and compelling to me that we would put together a repository that would provide clinicians who are eager to do a bit more with great measures that fit with a clinical environment. And so I'm not saying anything that's surprising anyone, but I do want to point out that kind of scope issue as we go forward.
Yeah, that's actually one of the reasons I really like how they approach the papers ratings, is that they do have cost, ease of use, ease of interpretation.
Sure.
Which some of those things as a researcher we take a little bit for granted. I'm like, I don't care if it's not easy to interpret. I can pay somebody to do that.
Yeah.
That's the case in a lot of situations. So I really like the thoughtfulness that went into that, and of course, like just the pragmatic nature of the measures. Just having this not be something that's going to require a patient to sit there for 30 minutes to fill out 4 measures, because all of a sudden that's never going to happen. So
right.
Yeah, Bill.
JD, just a great presentation, and I was only able to join 30 minutes after the hour, so
all the good stuff was after 30 minutes. So yeah.
Well, okay, yeah, you rambled until 9:30 my time, right? Okay.
Exactly.
I think that in line with Jody was saying too. What I think is important is reach. So I don't think we should just be focusing on the research perspective or just the evaluation clinical utility. What's important to me is access, and I actually really like your slide number 17, which seemed to really identify a number of questions that this group or some group within CFHA really needs to discuss. In terms of, I hate, like many people, I hate redundancy. So, whenever there's an opportunity for us to direct members to a repository that can be, that could be very helpful, because I would assume most members don't even know the presence of a lot of these repositories. So I think that for me, what I love was the consolidation of some of the questions and issues that I think this group or someone else needs to kind of really discuss. And I do like just the idea that CFHA would be able to at least like strongly support. We're not mandating anything, but we can encourage and make our own evaluation to try and get some kind of compatibility of what is being collected across different health systems.
Yeah, and actually, I initially didn't love the idea of like endorsing per se, but there's part of me that actually does kind of like that. And actually going to, making like Phenex or some of the other tool repositories actually useful for CFHA members, because they're exhaustive. They're not going to be great, for someone to just go peruse. If you just said, hey, there's really great depression measures within Phenex, that's not that helpful. I mean, what would be nice is to actually say, here are some measures that we have vetted and we have reviewed. They're available in the Phenex toolkit, but here's like the 3 or 4 that you really might want to consider, and maybe even having like a little couple bullet points for why these ones are ones that you may consider using, and it might be kind of highlighting some of those features that were part of the review process or part of the rating process.
Absolutely. Yep.
Yeah, hearing you say that, it struck me that what CFHA may end up doing is roughly the equivalent of an executive summary. So, you have a giant white paper that's 500 pages that no one's going to necessarily go through, but you'll look through the 6 pages of the executive summary that'll take you to links of what you want to do. And so I think, for both researchers and clinicians and health systems, in my opinion, I think what CFHA can do is really serve, like you were saying, Bill, as a facilitator to help people kind of get what they want, to make it as easy as possible, a trusted organization where they don't have to shift through all the science stuff, because I don't think most people really want to do that. And even if they're geeked about that, it can also be, a bit of a burden given everything else they're probably doing. So I think there are a lot of different directions that we could go in. I like your idea of, not repeating work that people have already done. And I think we could be a facilitator and, pointing people in the right direction, making it as easy as possible for folks to get what they want and giving them a little guidance on how to think about that. Or even, hey, if you want to talk with someone, here's a couple of emails. Please reach out to us. We're happy to talk to you.
Yeah, and I had initially thought, after seeing the questions that you all had and just starting to brainstorm for myself about what to present, I had initially thought like, hey, this is kind of a situation of like, a systematic review of systematic reviews. Like, people have already done a lot of the review work. Could you just, summarize and kind of review their work? But I was unable to find a lot of, the kinds of measures that I think CFHA would be interested in, which is why I sort of wanted to go through the whole process of, okay, if you're going to look for other things that you'd want to include, here's what it's going to take. Because some of those things around, really integrated care and whatnot, I just don't know if there's anybody who's done the front end work, but it could help really narrow the scope and just make it so it's a very, a more feasible project for CFHA to take on.
I was kind of just thinking about the executive. I totally agree. I think the utilization of CFHA to link members with some of this existing stuff is a really great idea. I personally don't know if I'm a big fan of the executive summary, but I was kind of wondering about a case series, like where maybe we have a group that comes up with like a case series of like, hey, we use this measure, we found it on this repository, and this is how we use it in our integrated care practice, or this is how we use it in a program evaluation. And then that creates our executive summary at the end of a year. So let's say, I don't know if we'd have one a month, but like we have a select number of cases, and it would demonstrate exactly, Chris, what you were saying with like the executive summary, but it wouldn't be an executive summary that I would never read because I find executive summaries too long. But that's only me. But I kind of like this idea of like the case, like Bill, you were saying, like, if we could just exemplify how we would use these things. And then that would also help us identify the gaps too. Like JD, you were saying, like, what is missing? I'm not certain I know what's missing yet, because there's so many different repositories. It would take a little bit to figure out what is missing exactly that would need to be filled in.
Yeah, Bob.
So JD, I'm going to be the first to throw my hat in and say, if you need somebody to help you piece this thing together, just reach out, because it seems like there's going to be a lot of work here, but I have a little bit of experience in this and love to work with you on it. So.
Awesome.
Well, it looks like we're 1 minute to the hour. Any other questions or thoughts, comments?
When is our next meeting?
We're working on it, Astrid. We're not sure yet.
Okay. We don't
I'll
have,
let you know.
We don't have one typically in the month of October anyway, because we have the conference. So
you'll be sending out the information. Yes?
definitely not in October. But if you come into the conference, Astrid, you can join us there. We'll be meeting bright and early at some ungodly hour. I think it's 7 a.m.
You will send out information about when our next remote meeting is.
Yes, we'll miss you.
Thanks, JD.
Yeah,
Thanks, JD. It was nice seeing
Awesome.
you.
you. Take care.